Good morning. In this video, I will show you the main steps of total knee replacement surgery, which is now a routine operation. The knee joint is formed by the lower part of the femur and the upper part of the tibia, as well as the patella, which is the circular bone located in front of the femur and tibia. Knee replacement can be total or partial. In the latter case, as you can see in the image on your right, only part of the knee joint is replaced with artificial components, while in the case of total replacement, almost always only the femur and tibia are replaced, and only in some cases is an artificial component also implanted on the patella. Surgery is performed in cases of severe joint degeneration, commonly known as osteoarthritis. Osteoarthritis can be primary, which means not linked to a specific cause other than advanced age, and often affects other parts of the body such as the hip or fingers, or it can be secondary. In the latter case, it can be related to an old fracture that affected the surface of the cartilage, or a rheumatic disease, or chronic instability due to an old knee ligament injury. The classic symptoms of osteoarthritis that lead to surgery are 1. Pain, which in the more advanced stages can even prevent comfortable sleep. 2. A feeling of joint collapse. 3. A feeling of stiffness. And 4. Recurrent swelling of the joint. As far as diagnostic tests are concerned, a simple X-ray taken while standing, rather than lying down on the X-ray bed, is sufficient to understand exactly the degree of joint collapse and therefore the degree of cartilage degeneration. This is an X-ray of a normal knee without osteoarthritis, in which we can see the red line indicating the articular surface of the femur and the yellow line indicating the articular surface of the tibia. Between the two lines, we can see a space that, in the case of osteoarthritis, is significantly reduced until it disappears, as in the image on the right that you can see now. The surgery requires general anesthesia, also called narcosis, or even better, partial anesthesia, called spinal anesthesia, in which only the legs are numbed by administering an injection in the back. After thoroughly disinfecting the entire lower limb, we make an incision in the skin approximately 15 centimeters long. Although the incision can be a little shorter, keep in mind that this could cause greater distress to the muscles, tendons, ligaments, and skin. Because in order to see what we are doing clearly, we would have to pull the soft tissues more. I do not normally use a pneumatic tourniquet on the thigh to reduce bleeding during surgery. In fact, it is sufficient to perform more accurate hemostasis with an instrument that burns the bleeding vessels. The major advantage of not using a pneumatic tourniquet is that it avoids secondary muscle damage due to compression of the thigh muscles, thus allowing for a more rapid functional recovery of the knee in the following days. The same instrument we use to coagulate bleeding vessels is also used to cut deep, soft tissue, with the undoubted advantage that this instrument cuts and coagulates arteries and veins at the same time. In a few steps, we reach the joint capsule, which we open with a curved incision, again using the electric scalpel, which in this case also allows us to coagulate the arteries and veins at the same time as we cut the tissue. Opening the joint capsule involves moving the patella, to which the quadriceps tendon and patella tendon are attached. The patella is moved toward the outer edge in order to have a perfect view of the articular surfaces of the femur and tibia. Now we can start using the instruments that will help us make the bone cuts, which must be precise and perfectly flat. It is thanks to these instruments that we can plan the degree of correction we want to give to the knee axis. In the case of the tibia, the cutting guide is stabilized in the desired position with 3 temporary metal pins, which prevent the guide from moving while we use a saw to cut the bone. After completing the cut, we remove any soft tissue that is still attached to the bone. As you can see, the bone cut is now limited to a few millimeters in thickness. Once the tibial plateau has been cut, we move on to cutting the femur, which involves several steps in a precise sequence. Please note that bone cuts must be made with a saw, because bone is a rather hard and resistant tissue. The first of these steps is the vertical cut, followed by horizontal and oblique cuts. The special feature of this guide is that it has several grooves to guide the saw in different directions without having to change the guide each time. Once this phase is complete, both the femur and tibia are ready to receive the prosthesis. Before implanting the final prosthesis, however, we must check the mobility and stability of the knee with temporary components. Let's now move on to the final stage. While the surgeon uses a kind of gun that washes and simultaneously aspirates sterile water, the surgical technician begins to prepare the sterile cement. In fact, to ensure perfect and immediate adhesion of the prosthesis components to the bone, a kind of superglue is used, which is prepared by mixing a powder with a liquid that triggers a chemical reaction. This reaction takes place under vacuum. The surgical technician mixes the components until, after a few seconds, a paste is obtained, which is then applied to the prosthesis components that will be applied to the bone. The surgeon now places the component on the tibia first, followed by the component on the femur, taking care to remove any excess cement that may come out when each prosthetic component is pressed into place. It takes between 12 and 15 minutes for the orthopedic cement to harden completely. When the cement is completely hard, we insert the plastic component, or rather, the high molecular weight polyethylene component. The purpose of this plastic component, which is very resistant to wear, is to artificially reproduce the joint space between the femur and tibia, thus preventing the two metal components from touching each other. Now all the components are in place and stable, all that remains is to check the mobility and stability of the knee once again. Before closing the surgical wound, we apply our local pain relief protocol to both the deep and superficial layers, which will ensure excellent pain coverage. Which is generally very well tolerated, despite what you may think when you see these images. The last stage of the surgery is to close the capsular capsule first and then the layer under the skin, using a resorbable suture. The skin will be closed with metal staples, which will be removed after 2 weeks. The aim of the surgery is to try to get you walking again as soon as possible without difficulty. After the surgery, you can immediately put your full weight on the leg, although at the beginning, it will obviously be better to ask the nurses and physiotherapist for help. The patient whose surgical images you saw the day after the operation is already walking, using a walker and without pain, thanks to the pain relief protocol set up by the anesthetist. Here you can see the same patient again, 2 days after the operation, using crutches for the first time. These will be gradually abandoned over the following weeks, thanks above all to the fundamental help of your physiotherapist. As I said, you can put your weight on the ground immediately, but it will also be essential to start mobilizing the knee as soon as possible using this tool, which flexes and extends the joint in a very gradual and gentle way. After 5 to 7 days, you can go home, where you will continue physiotherapy with the device I have just shown you and with the physiotherapist who can come to your home, or you can go to their office. Alternatively, you can also be transferred to a rehabilitation center where you will stay for about 2 or 3 weeks. In medical literature, 85% of patients report being very satisfied with the results achieved by the surgery. However, there are several risks and complications that can alter a good outcome, and that you should obviously discuss with your surgeon before the operation, carefully reading the information brochures you will receive. Many patients rightly ask how long the implanted prosthesis will last. The answer is quite encouraging because, according to medical literature, after 20 years, 96% of prostheses are still functioning well. Thank you for your attention.